كلكم to be here today. So this is going to be a series of lectures. Salah has organized them. As usual, I know you have done a lot to the fellows, and it is my honor to be part of this. So let us just start. The first topic on this series will be oncologic emergencies. So what I would like to make this a little bit interactive, so you can keep us awake and follow the slides and the presentation. I'm going, for each part of the session, it's going to be a case, but you do not have to answer. So just you can answer to yourself, so that way you can correct yourself when we go through the presentation. So every session will be preceded by a short case presentation with some questions. As I said, if you have a question, you can raise your hand. You can ask. You can stop me, and you can raise your hand, and we can leave the question to the end. But I want to make it a little bit interactive. Okay. So, introduction to the oncologic emergencies. You can say this is acute events with high morbidities and mortalities. It could be directly or indirectly related to the tumor, or it is treatment. So we could be the cause for the oncologic emergencies by what we do. The key for this session and to save life, the treatment of oncologic emergencies is a life-saving, you could say. And that is achieved by high level of suspicion. So you have to be very vigilant and just with a high suspicion for complications. And then early detection, and of course, patient education, to let the patient know what to expect from the treatment and from the cancer, so they can present themselves correctly to the ER or to their doctors. So being suspicious is the key to treat those morbidities and mortality, avoid morbidities and mortalities. So we are going to, I'm going to cover, I think, 7 of those oncologic emergencies. The first one will be neutropenic fever, sepsis, or septic shock. The second is tumor lysis syndrome, which includes hyperkalemia, hyperphosphatemia, hyperkalemia, and hyperuricemia. And then hypercalcemic malignancy, number 3. Number 4, hyperviscosity syndrome, and then immune-related toxicity. I added this on my own. I don't think it's in the textbook yet, but it's just because of this new class of medication. And superior vena cava syndrome, and last would be neoplastic epidural spinal cord compression. So we'll cover these 7 sessions. So now we'll start with the neutropenic fever or sepsis syndrome. This is just brief introduction. Chemotherapy affects the rapidly dividing cells, of course, which is the malignant cells, and we're not sorry. That's what we're trying to do, to destroy those malignant cells. But unfortunately, the normal cells are not safe. They could be destroyed. And this is specifically the rapidly dividing cells, which look like cancer cells to the chemotherapy. Blood cells, specifically neutrophils, which lead to neutropenia. This is our topic. Mucous membrane, mucositis, hair follicles, and that's why chemotherapy causes alopecia. So those are the rapidly dividing cells. So this is just a quick reminder for ourselves for the cell cycle. So the G1 phase, which is the gap phase, where the cell grow and prepare to DNA synthesis. The S phase, which this is the S phase, which is the synthesis phase, where the cell synthesizes its DNA, and that is the most sensitive phase to chemotherapy. So chemotherapy hit in the S phase. And then the G2 or the second gap phase, which is where the cell prepare to divide. And this area is sensitive to radiation. I'm not a radiation oncologist, so my knowledge about radiation oncology is very limited to nothing. The training is mainly hematology, oncology, or some hematology. That's just a type of training in the state. The M phase, which is a phase also to some extent the cell is sensitive to radiation. So how the chemotherapy affect the blood cells? During hematopoiesis, which is the differentiation of blood cells, as you know, cells are very sensitive to chemotherapy and most likely to be damaged, as we said, and that is in the S phase. That leads to diminished production of new mature cells. So the cells that are mature are already mature, but new ones will be damaged. So mature cells, neutrophils or platelets, then they live their lifespan, and after that, there are going to be no new cells. That's why the white cells and platelets drop. So the absolute neutrophil count, the ANC, falls to its nadir, and we'll talk about the nadir. So this is just a cartoon for the hematopoiesis. Remember the stem cell, myeloblasts, promyelocytes, myelocytes, and then metamyelocytes, bands, and neutrophils. This is a series of cell production inside the bone marrow. So during this series, the chemotherapy is going to hit right here. So whatever is being produced is produced, and none to very little or very few of cells will be produced. And that is how the chemotherapy causes neutropenia. So what is the nadir? Nadir of the ANC is the lowest blood counts following a chemotherapy cycle. So the nadir usually typically between 7 to 14 days after chemotherapy. And it varies, depends on the chemotherapy drugs and chemotherapy regimen. The next dose of chemotherapy is given only, should be actually given only after the nadir. So this is just a cartoon showing that is the nadir, it depends on the regimen. This is a different regimen. You can see the nadir could be 10 days, 12 days, 21 days, depends on the regimen. So we should never start chemotherapy right here. We should usually start the chemotherapy on the uphill when the cells start going up. So chemotherapy here, if we do here, we just end up with bone marrow aplasia. So this is a case. So, 57-year-old female patient with history of SLE, recently diagnosed with metastatic non-small cell lung cancer with metastasis to the liver. She received the first cycle of palliative chemotherapy, docetaxel, cisplatin, about 2 weeks ago. So that means we are in the nadir. So she was brought by her family, lethargic and dehydrated. Her blood pressure 90/60, pulse 110 per minute, temperature 38.3 Celsius, a respiratory rate 24, and she had mucositis. Her lab, remarkable for absolute neutrophil count of 0.2, so she's very neutropenic. You immediately triage and establish the patient and stabilize the patient. You took 2 sets of blood culture, one from peripheral, one from central line, and decided to give antibiotics. So now the question, what is the critical time window of giving the first dose of antibiotics? You don't have to answer to yourself, see if you got this right or wrong, but this is very critical. So what is the critical time window of giving the first dose of antibiotics? And what is your empiric antibiotic of choice? So now she is in a septic shock, unfortunately, and you have done all that you could do. What is the mortality rate for this patient? So those 3 questions, try to answer, and we'll answer them through the presentation. So definition of neutropenic fever, it is a single oral or auxiliary temperature of 38.3 Celsius or 101 Fahrenheit. Or a temp of 38 or more Celsius, 100.4 or more Fahrenheit for sustained for more than an hour. Plus, of course, severe neutropenia. So severe neutropenia means absolute neutrophil count of 0.5. So this is the definition of neutropenic fever. So not all neutropenic fever is due to documented infection, not necessarily infection. The neutropenic fever doesn't mean infection. So sort of infection, if any, is identified only in 20 to 30% of patients. Bacteremia, 10 to 25%. And the most common is indigenous flora from the patient or flora. Gram-positive and gram-negative are the common. Pseudomonas aeruginosa is the most serious sepsis. The most serious is Pseudomonas. So hematologic malignancy on chemotherapy, actually that is make 80% of the neutropenic fever cases. Solid tumor on chemotherapy makes 10 to 50% of neutropenic fever cases. Neutropenic fever depends on type of chemo, duration of neutropenia, severity of neutropenia, with an absolute neutrophil count, as we said, typically less than 1.5, but less than 0.5, that's a severe. The nadir, the common nadir is 7 to 14 days post-chemo. That's for the most doublet chemotherapy, like carbotaxol, docetaxel, cisplatin, any of the platinum, any doublet. The mild neutropenia is considered if ANC is 1 to 1.1, less than 1.5, moderate 0.5 to 0.9, and severe is less than 0.5, and profound neutropenia ANC is less than 0.1. The common bacterial infection is the indigenous flora, as we said. If it is from the gut, is the E. coli, skin is staph, respiratory streptococcus. Gram-positive, the common is streptococcus, staph and streptococcus. The gram-negative is E. coli, Pseudomonas. Nowadays, the resistant gram-negative is increasing, unfortunately. If the patient has an indwelling catheter like Hickman, Porter cath, staph is common. C. diff, if the patient has diarrhea. Fungal infection. We suspect fungal infection if a patient has prolonged persistent neutropenia for more than 4 days, and the common is Candida or Aspergillus. So initial evaluation. We suspect neutropenic fever if a cancer patient had chemotherapy within the last 6 weeks. So the history, if the patient said had a chemotherapy within the last 6 weeks, come with fever, we suspect neutropenic fever, and we work accordingly. Vital signs, of course, we check the vital signs. We obtain an IV line. Medical, this is the key. So medical assessment should be within 15 minutes of triage. So this patient should not wait in the ER. And then if the patient has any of the systemic inflammatory response syndrome, which are written here, I think you're all aware of that. So if the patient has any of the systemic inflammatory response syndrome, plus or minus altered mental status, those patients should receive antibiotics within 30 to 60 minutes. That's a question for the window. You remember the question? We said this is the window. If the patient not receive the first dose of broad spectrum antibiotic in more than 60 minutes, an hour, the mortality rate increase significantly. So if the patient end up in the ER, our window is 30 to 60 minutes to receive the first dose of antibiotics. The studies show that antibiotics after an hour is really means diminished outcome. So if a patient end up with neutropenic fever in the ER, the first thing, give 1 dose of broad spectrum antibiotics after the 2 set of blood culture, and then the rest will come. But the first dose of antibiotics should be given immediately. Of course, the patient should go to a monitored bed, ICU, if available. So diagnosis, of course, is clinical. The workup is right here. This is just a serum lactate more than 4, serum procalcitonin more than 0.5. This is just a workup. Treatment, of course, as we said, we give after 2 sets of blood culture, we should give a broad spectrum antibiotic within 30 to 60 minutes. That's the answer for the first question. The window is 30 to 60 minutes. And then the second question, what are the best antibiotics to give? The best antibiotic for neutropenic fever patient is the 4th generation cephalosporin, which is Sevapine, 2 gram IV every 8 hours. Give the first dose in the ER, you save the patient. If you pass 1 hour, the mortality is high. The second option is beta-lactam, which is meropenem, 1 gram IV every 8 hours, or Zosine. That's also 3rd generation cephalosporin is reasonable. That is fine, but the Sevapine is the best. When we give vancomycin, we give the vancomycin if the patient has an enduran catheter, Hickman catheter, Portocath, central line, you give a dose of vanco. If the patient is hypertensive, give a dose of vanco. The skin or soft tissue is a source of infection. Patient with had a wound, gave a dose of vanco, or a patient already on fluoroquinolone, Cipro, ciprofloxacin, Levaquin, or a Bactrim, a patient already on those, then give them a dose of vanco. In addition to the cephalosporin. Of course, you need an ID consultation. Anaerobic coverages, we give Flagyl and one of the carbapenems, which is like Invance. And this is when you give those for the anaerobic coverages. Antifungal for high-risk patients, patient with persistent fever, prolonged fever for more than 4 days. And here are the antifungals for Voriconazole, amphotericin B. Catheter-related bacteremia. If a patient has bacteremia, documented bacteremia, and has a catheter, the first thing to do is to remove the catheter. That's the best treatment. Of course, and this is the organisms. What is the role of GCSF? There is no clear benefit in established neutropenic fever. GCSF, if the patient already presented with neutropenic fever, the role of GCSF is kind of unknown. Infectious Disease Society of America, they said it is not recommended for routine use in patients with established neutropenic fever. So it's already done. However, the American Society of Clinical Oncology, ASCO, and National Comprehensive Cancer Network, NCCN, they put this kind of diplomatic kind of statement. They said, considered for high-risk patients for infection-associated complications or who have prognostic factors that are predictive of poor clinical outcome. So they didn't say don't give it, but they said everyone agreed that it is for prophylaxis. So you give it as prophylaxis, but not as a treatment. So that means it is better to give it within 72 hours of chemotherapy to prevent. But once neutropenic fever occurred, then the benefit is really kind of limited, unknown, and as we said here, the Infectious Disease Society of America, they said it is not recommended. Just waste of money. You can see this. So here, I think this is kind of covered. So this is, I think, trying to say that it depends on the severity. Oh, I see. So the neutropenic fever depends on the severity and the duration of the disease. So if you have a neutropenia plus mucositis, which is a place for colonizing bacteria and fungi, and in addition to that, if you add one of the SIRS, that leads to that's a neutropenic fever. Then your empiric antibiotic should be given within less than 60 minutes, within an hour. After that, that is patient may end up with sepsis syndrome, and that is the mortality right there. So even with your treatment, with everything that you do right, hydration, antibiotics, everything, ICU, the mortality rate is 30 to 40% with treatment. Of course, without treatment is almost 100% death. So the mortality rate with treatment, those patients will lose 3 out of 10 or 4 out of 10. So it is serious. Of course, that is death. Now we move to a second topic, which is the tumor lysis syndrome. A case: a 35-year-old male patient recently diagnosed with stage 3B diffuse large B-cell non-Hodgkin lymphoma, received the second cycle of R-CHOP 10 days ago. So this is a nadir. He presented with shortness of breath, lightheadedness, and nausea. Here is the lab. Chemistry, creatinine is 2.3, potassium 6.2, and here the normal for our lab here. Uric acid 9.8, calcium 5.8, and phosphorus 5.3. This is the lab. So you're allowed to order only one test other than lab. What that test is? Take a minute, answer yourself. So what that is? That test is an EKG or ECG. And here is the ECG findings, which is characteristic for hyperkalemia, correct? So that patient had the hyperkalemia, and that is due to, the hyperkalemia, EKG change is due to hyperkalemia. So question, which electrolyte you may have to correct first and why? I think I answered that already, the potassium. And why? Because potassium causes EKG changes, cardiac arrhythmia, and cardiac arrest. So it is serious. So it's fatal if not corrected. So what is your drugs of choice? You can answer yourself and we'll go over those. What is the precaution that you may have to make if you decide to correct the calcium? Remember, this patient had hypocalcemia, low calcium. So what precautions you need to take before you correct? So don't just see the calcium as being low and correct. If you decide to correct, you have to be prepared for something. What is the drug of choice for his hyperuricemia? The drug of choice. We're going to talk about that too. Everyone follow me, or am I going fast, or am I confusing, or?
أعتقد دي فرصة يعني just to be interactive session.
Okay, sure.
If one can raise, just he can unmute himself and answer, or he can put in the chat box. I think we need.
I don't want to put people on the spot, but that's okay. No. If you want to unmute and just go ahead and answer. So, what is the drug of choice for hyperkalemia? Anyone?
وليد. دكتور وليد. أنا حسأل زي الألفة بعد ده.
أيوة دكتور صلاح.
Yes, if you can just interact.
Usually, hyperkalemia management as an patient, you will start first with calcium gluconate to stabilize the cardiac muscle, and then you will correct with an insulin or salbutamol or whatever.
So exactly. So this is a two drug. And by the way, yes, we need to remember, calcium gluconate, so calcium chloride, does not lower the potassium. So when you give it, don't expect the potassium to be low, to drop, correct? So it usually just protect the cells from the high calcium, high potassium. So it does not lower the potassium, it just protects from the effect of the potassium. That's it. But the insulin lower the potassium, correct? But those are the two drugs. So what is the precaution you may take if you decide to correct the calcium? This patient has a calcium of 5.6, very low, but if you don't have, usually you don't have to correct the calcium, but if you decide, you have to be very careful. Remember, this patient has a high phosphate. I'm just giving you a hint. So high, if you decide to give calcium, and the patient has high phosphate, develop calcium phosphate, correct? And that is precipitate in the kidneys and cause kidney failure. So if you see the calcium high and the phosphorus is high, I mean calcium is low, phosphorus is high, be very careful in correcting the calcium because you may create another problem. So what is the drug of choice for hyperuricemia? Anyone? I think everyone knows.
Somebody should answer.
Let me ask you another question. What about allopurinol?
Allopurinol is used for uric acid as treatment.
Correct, exactly. Great, that's right. That's a key. So allopurinol is for prophylaxis. So once hyperuricemia occurred, then allopurinol does not lower the uric acid. So allopurinol is for prophylaxis, as you said. We'll go over that. So introduction. So tumor lysis syndrome is the release of intracellular components in blood, which is uric acid, potassium, phosphate, that's what you mentioned, and nucleic acid catabolism due to hyperuricemia, which lead to acute kidney failure, hyperkalemia due to arrhythmia and cardiac arrest, hyperphosphatemia, hypocalcemia, this component, that's what we said. We do not correct the calcium immediately. We have to be very careful, especially if the phosphorus is high, that lead to calcium phosphate, and that lead to acute kidney failure. So do not correct the calcium immediately. And if you decide, just be prepared for what could happen. And so hypocalcemia lead to arrhythmia. So sometimes if you see arrhythmias, you may need to correct the calcium, but very carefully. Mortality rate from the tumor lysis syndrome, 29 to 79%. So is bad. So here the definition for the tumor lysis syndrome. To define tumor lysis syndrome, you have to have 2 or more of metabolic abnormalities: high uric acid, high potassium, high phosphate, low calcium. You need 2 or more of those to call it tumor lysis syndrome. Plus, and that could happen within 3 days before chemo. Like Burkitt's lymphoma, you could have a spontaneous tumor lysis syndrome, correct? Or within 7 days after chemotherapy. That is due to the killing of the or destroying of the tumor cells. However, nowadays there is a drug for which is a BCL2 inhibitor for the CLL or the small lymphocytic lymphoma, that Venclexta, and that could actually cause hyperuricemia within 6 to 8 hours. So immediately, this drug is very powerful. And then you need that's a laboratory definition. A clinical definition, you need the lab test plus 1 or more of the therapy related, which is creatinine more than 1.5 upper normal, arrhythmia or sudden death. This is a clinical definition, or seizure. So that's the definition for the tumor lysis syndrome, laboratory and clinical. Risk factors: tumor with rapid tumor cell turnover, large tumor burden, solid tumor highly sensitive to chemotherapy, like a small cell lung cancer, that's a solid tumor, or hematologic malignancy, acute leukemia, Burkitt's lymphoma, spontaneous tumor lysis characterized by spontaneous tumor lysis, CLL or SLL on Venclexta, BCL2 inhibitors. Those are all risk factors. So if you give patient Venclexta or the BCL inhibitor for CLL, those patients should be either given IV in hydration or sometimes given in the hospital, because the tumor lysis could happen within 6 to 8 hours. Baseline insufficiency, renal insufficiency, elderly with comorbidities, and of course, polypharmacy. Presentation: fatigue, dehydration. Just gonna go quick. This is a presentation for the tumor lysis syndrome. Diagnosis: you need a comprehensive metabolic panel, renal and hepatic function, uric acid, of course, total and ionized calcium, phosphorus, LDH, ADCG, and urine analysis. And of course, you need a CBC. So treatment of tumor lysis syndrome, how we treat. First of all, prophylaxis. Depends on risk for tumor lysis syndrome, tumor burden, types of malignancy, comorbidities, so hydration, and as you said before, early allopurinol for prophylaxis, but respiracase is for treatment. And when you give respiracase, just to be aware of the G6PD deficiency. Frequent chemistry lab, you do maybe twice a day if in the hospital, or even more frequent. Cardiac monitoring, general measures, aggressive hydration, you need fluid, you give 2 to 3 liters per day. Correction of electrolyte imbalance, of course. Review of medication, hold any medication that could cause a harm, like ACE inhibitors, hold those or discontinue them, and no NSAID, of course, because of renal toxicity. Hyperkalemia, I think Walid mentioned that early. For the rapid effect lowering of potassium, the IV calcium protect against potassium cardiotoxicity. It does not lower the potassium. We mentioned that. So it protects the cardiac cells or the from the hyperkalemia, but it doesn't lower the potassium. It can give calcium gluconate 1 gram, which is 10 ml of the ampoule. Usually comes in a 10 ml of 10% calcium gluconate, or calcium chloride is also okay. 500 to 1,000 milligram IV. Insulin, that's lowered the potassium, and that is, so we have to check the glucose first. So you have to make sure patient if it's diabetic, blood sugar less than 250, and you give 1 amp of 50% dextrose, followed by 10% dextrose, and you need to monitor blood sugar very frequently, especially for diabetic patients. Or you could remove the potassium by the GI cation exchangers. Typically here we use the K-oxalate. It's a mess. When you give it, just it causes diarrhea. Yeah, it's a mess. But that is the way to remove the potassium. Hydrolytic diuretics. Of course, hemodialysis is refractory cases, hypervolemic patients with the congestive heart failure. You could use diuretics, of course. Metabolic acidosis, you could use bicarbonate, and of course, nephrology consultation. Hyperphosphatemia treatment. If the phosphorus is more than 6 milligrams per deciliter, you may need to treat, but not all the cases. If you treat, use aluminum hydroxide. For hypocalcemia, as we said, if we treat, we have to be very careful. Asymptomatic, monitor, don't treat. Don't treat the lab. Don't treat the lab just because of the calcium is low. Don't go to the pharmacy and pick up an amp of calcium chloride, gluconate, and give to the patient. You may create more problem. It causes calcium phosphate crystals in precipitation in the kidneys and cause obstructive uropathy. Symptomatic hypocalcemia, yeah, as we said, you could give the calcium gluconate as needed, but with a lot of precautions. Hyperuricemia treatment. As we said, allopurinol only for prophylaxis. It does not lower the present uric acid. It doesn't lower it. So yeah, if the patient already come with the uric acid of 9, give them uric acid, giving them allopurinol, you just to treat yourself. But if you would like to treat respiracase, and why? Because it metabolizes the uric acid, change it to allantoin, which is renally excreted. Hemodialysis, we use it for severe refractory tumor lysis. So it is the last resort. Acute renal failure, severe hyperuricemia, severe symptomatic hyperkalemia, muscle weakness, paralysis, arrhythmias, hyperphosphatemia of more than 6 milligrams per deciliter, symptomatic, of course. Now we move to another type of tumor of oncologic malignancy, which is hypercalcemia of malignancy. This is a case, 55-year-old female patient with history of triple-negative breast cancer with extensive osseous metastasis. She is in your clinic for her usual chemotherapy cycle. She has mild nausea and constipation, which she contributed to her opioid pain medication. So she's minimally symptomatic. This is a typical symptoms for those kind of patients. But when you did her vital signs are stable and appears slightly dehydrated, and you get the lab, and you get the lab back, and here's the lab. Your serum calcium, total serum calcium 12.8. This is for our lab here. I think you use a different units, but it's 12.8, normal 8.5 to 9.5, albumin 2.0, creatinine 1.7. Your lab does not, your lab not capable to perform ionized calcium testing. So this is the total calcium. So you don't know the real calcium, which is the ionized calcium. So what is her corrected calcium level? So you need to now to use your math. You need to remember the equation, how to calculate the serum calcium. So at what serum level you may become very concerned that she is at high risk for cardiac arrest, and you may have to treat her regardless of her symptoms. Anyone give me a number? Cutoff number? It's the exam test. What is the calcium level? Above that, you treat regardless of symptoms. 14? Yeah, 14 or more. If just remember the number 14, serum calcium, corrected serum calcium, and we'll go for we'll see the equation for the corrected calcium. So calcium of 14 or more, you treat regardless, because that is found to be a high risk for cardiac arrest and arrhythmias and cardiac arrest. So any calcium less than 14, 12 to 14, we call it moderate. We treat case by case. Less than 12, we don't treat. We treat the cause. But 14 is considered the cutoff to treat regardless. So hypercalcemia malignancy, 10 to 30% of patients with malignancy develop hypercalcemia. The mechanism, here are the different mechanisms. I'm going to go quickly. This is how malignancy causes hypercalcemia. Presentation, anorexia, nausea, vomiting, constipation, malaise. This is the symptoms. This is the presentation, diagnosis. Total ionized calcium. Ionized calcium is the diagnostic, but if you do not have, if your lab does not perform ionized calcium level, you can do your calculated corrected calcium, which is the measured calcium plus 0.8 times the difference between 4 to the patient's serum albumin. So that patient has a 12.8, add to it 0.8, and her albumin, I remember, was 2.8, so 2.2 times 0.8, then you come up with calcium almost close to 14. This is the equation for the corrected calcium. You need to check your electrolytes, PTH, you need an EKG, treatment for hypercalcemia. If it is mild, remember we said if the corrected calcium less than 12, that's called mild, does not require immediate treatment, you treat the cause. Avoid aggravating factors, of course, thiazide, dehydration. Moderate is considered 12 to 14 milligram per deciliter. That's a moderate hypercalcemia. Corrected calcium of 12 to 14. That's moderate, that's case by case. Treat if symptomatic. But the severe hypercalcemia is considered calcium of more than 14 milligram per deciliter. That is considered severe. Even if the patient is asymptomatic, you need to treat to lower the calcium due to high risk for cardiac arrest, and it's considered an emergency treatment. Treatment, aggressive hydration, very generous, to be very generous. 1 or 2 liter isonic fluid. Of course, you monitor the INOs, input and output. High dose loop diuretics, especially congestive heart failure. Biphosphonates, You could use that, or use the Dexiva or denosumab for refractory to zoledronic acid. Calcitonin could work too, but it doesn't last. Steroids, could use steroids, and of course, a very last hemodialysis for severe hypercalcemia or oliguric renal failure. Another topic, which is hyperviscosity syndrome. Case, 75-year-old male patient with history of Waldenstrom macroglobulinemia on observation. He presented with blurring of vision, headache, and shortness of breath during exertion. Lab, remarkable for serum IgM of 5.2 gram per deciliter. So you suggest hyperviscosity syndrome. What lab test you may order to confirm the diagnosis? What single lab test you need to do to confirm your diagnosis? And what is your immediate course of action? The best treatment for hyperviscosity syndrome. Not treating the Waldenstrom macroglobulinemia itself, that's later on, but for now, for the immediate action. Anyone?
بيهم 20 ثانية كده ويسهر واحد. ما في.
I'm not sure, but I think giving IV fluid or plasmapheresis, but immediate, I think IV fluid.
Say it again.
صوتك يا وليد.
I think you said it right. Did you say plasmapheresis?
Yes, exactly,
Yeah.
plasmapheresis, but I'm not
Yeah.
sure if it's possible immediately.
Yeah, that's what I heard. Yes, yeah. So the immediate course of action for a patient with the IgM of 5.2, and the test is viscosity, serum viscosity. That's your test. So if your serum viscosity at the level of, I will go over that, what that level is. If you confirm that, you don't have to wait for the test. You can go with the symptoms. Patient with blurring of vision, headache, shortness of breath, this kind of symptoms, dizziness, these are symptomatic hyperviscosity, then yes, your course of action is plasmapheresis, which is actually it seems very fancy, but really any dialysis unit, I think they could do it, because basically that's not my expertise, but it is nephrologist does that. So whenever there is a dialysis machine, I guess plasmapheresis could be performed. So hyperviscosity syndrome, it is it leads to relative hypoperfusion and organ dysfunction, especially brain. Causes could be high protein, which is a Waldenstrom macroglobulinemia, multiple myeloma, IgM multiple myeloma, or acute leukemia with a high count, more than 100,000, or the polycythemia, especially polycythemia vera. This is the presentation, visual changes, the symptoms. Here it is, so your serum viscosity of more than 4 centipoise, that is a test to confirm your hyperviscosity syndrome. If the test is available, you can, more academic. The symptoms, this is a clinical diagnosis. But if you do the test, and that is just mainly for exams. So if you have a serum viscosity more than 4, that is diagnostic and confirmatory, and that means plasmapheresis is a must. Risk factor, IgM more than 4, WBC more than 100,000, hemoglobin more than 20 gram per deciliter. Diagnosis, routine, IgM, serum viscosity, CBC, treatment, IV fluid, plasmapheresis, as we said, leukapheresis. Plasmapheresis, of course, we remove the protein, the IgM. Leukapheresis, we remove the white cells. chemotherapy for leukemia, and phlebotomy for polycythemia. Now, a new item for the oncologic emergency now is being added to the list. It's immunotherapy related toxicities. Because this is a new class of medications. It's becoming in use quite a bit. It's almost replacing chemotherapy. And it is immune checkpoint inhibitors. And a lot of them now coming to practice. Those are the most common, the programmed cell death protein 1 inhibitors, PD-1 inhibitors, and there are now 4 of them, as far as I know. Maybe there are more, but they're coming. Opdivo, Keytruda, Pembro, Nivo, and Libtayo, Gemberli. So these are new class of medication being in use. PD-1 inhibitors, there are 3 of them now available in the market, being in use. And the cytotoxic T-cell lymphocyte antigen inhibitors, Yervoy or EPI, is being in use. So this medication they brought with them a lot of very specific complications. It could be an emergency. So how we manage them? So here is the case. This is actually a real case. This is one of my patients. He's an 81-year-old, one of a sad case. So 81-year-old female patient with history of smoking, diagnosed with stage 3B, non-small cell lung cancer. I treated her with the concurrent chemotherapy and radiation as very typical Taxol carboplatin during radiation concurrently. And her CT scan showed good response. She did well, she did fine. And then as by NCCN guidelines, this is the standard of care now, if a patient has no progression or response to the concurrent treatment, we put them on maintenance consolidation PD-1 inhibitor, durvalumab or Imfinzi. I did that, give her one cycle. She did fine, went home. 2 weeks later, she presented with dry cough. So vital signs is stable, except for oxygen saturation of 89% in room air. So chest X, I did the chest X-ray, was unremarkable. Just she had that right lower lobe mass, nothing else. But still, she's short of breath. Well, maybe there is something else going on. So remember, we said to be your suspicion should be very high. So I ordered a stat CT chest, and here is a CT scan. This is our CT scan. This is a real case. So this is a CT scan, and what do you see there? Are we seeing this fine infiltrate, correct? Easy could be missed, so just very fine infiltrates. So what is your diagnosis? For patient on immune therapy, with that fine infiltrate, it is pneumonitis until proven otherwise. But which sometimes looks very typical for viral infection or pneumonitis or drug pneumonitis. But here in this case is a PD-1 inhibitor pneumonitis. So that's called is an emergency. So the diagnosis is pneumonitis. At that time, consider it mild to moderate pneumonitis, so we treat as such. So what is your course of action? If you see pneumonitis due to PD-1 inhibitor or checkpoint inhibitors, I think you need to be aware of that. Even their drugs are not widely used. Here we use it a lot, but they're becoming more and more worldwide. They've been used a lot, but you have to be aware of complications because like this patient, unfortunately, I'll show you what happened to her, but it is serious. So you have to be very suspicious for pneumonitis. So the course of action, I immediately prescribed for her high dose prednisone, 1.5 milligram per kilogram, and then just close monitoring. She took it for a couple of days and she did okay. However, unfortunately, 2 weeks later, I got a call from the ER that she presented with worsening shortness of breath. Her respiratory rate was 22 per minute. Her oxygen saturation dropped to 75 from room air. She was on high dose steroid at home, doing fine. That's what we thought. Consult pulmonary just to see if there is something happened. But she presented suddenly with this respiratory rate of 22, oxygen saturation 75% in room air. The doctor we ordered a CT scan of the chest, stat, and here her CT scan. Terrible. So 5 lobes pneumonitis from the PD-1 inhibitor, which is development. So she has 5 lobes pneumonitis. What is your course of action at this point? After the steroid, we'll go over that. So pneumonitis, mild or moderate, we treat them outpatient with the steroid. Severe, of course, we discontinue the drug permanently. Monitor bed, ICU if available. Infectious workup, of course, we rule out, especially with this now with the COVID and all kind of viral infection. Bronchoscopy is indicated and may consider antibiotics. But the main thing is the steroid, which was already given. And we give steroids. We assess for response within 24 hours, taper over 6 weeks. This patient was doing fine, 2-3 days, we're doing okay, but later on she succumbed to her respiratory symptoms. If no response, that's the answer for the second question, what is the course for that terrible CT scan? At that time, we should give Remicade, infliximab. Infliximab 5 milligram per kilogram, and we repeat in 14 days. You give 2 doses, or IVIG or Cellcept, mycophenolate. So just be aware of these drugs. Any of these drugs could do it. Any of them, PD-1 inhibitor, PD-L1 inhibitor, Yervoy, any of these could present with, we call them the drug of itis. Pneumonitis, colitis, dermatitis, hepatitis, nephritis, any inflammation. It could be basically because these drugs causes the immune system to be hyper. It could attack any normal organ. The second severe, I just chose one of them because those are two serious ones, pneumonitis and colitis. Again, mild or moderate colitis, hydration, and just treat conservatively. But for severe, of course, we discontinue the drug, inpatient care, rule out infection, CT scan. But the most important is we start a steroid as soon as possible after we rule out C. diff. So prednisone, steroid, prednisone 1 to 2 milligram per kilogram per day, taper over 46 weeks, steroid immediately. Don't take a chance. If no response, again, you could use Remicade, infliximab, treat them as ulcerative colitis. Endocrinopathy, affect the thyroid, but not serious. But the most serious is hyperglycemia. Those patients could develop diabetes, type 1 diabetes. So we check for C-peptide with repeat serum glucose. So patients with the on immunotherapy could develop hyperglycemia, type 2 diabetes, type 1 diabetes, like a type 1 diabetes. General rules: rapid identification, interruption of the immune therapy drug, prompt initiation of systemic high-dose steroid. If you give high-dose steroid, remember to give them prophylaxis for PGP or PCP, prophylaxis. Also for high-dose PCP, we give usually Bactrim or give fluconazole for if you use a high-dose steroid. And for herpes zoster, like acyclovir, and remember the PPI to protect the stomach. Also, any patient on immunotherapy drug should be advised to keep a wallet card with the type of immunotherapy, because sometimes the doctors in the ER, they're not familiar with these drugs. Patient come with dry cough, they give them antibiotics, send them home, say viral infection, diarrhea, they call it gastroenteritis. So they could educate the ER doctor saying that I'm taking an immunotherapy, and my doctor said, if you don't give me steroid immediately, I may die from it. As simple as that. So those patients on immunotherapy should be treated promptly with steroids. So we move to a different oncologic emergency, cardiovascular emergency, SVC, superior vena cava syndrome. SVC syndrome results from external compression of superior vena cava by a tumor. Lung cancer is the most common, lymphoma, thymoma, non-malignant indwelling catheter or thrombosis of the superior vena cava. Presentation, facial neck edema, usually periorbital, distended veins, plethora of the face, chest pain, dizziness, also the symptoms. Then dizziness, syncope, lethargy, altered mental status, and eventually death. So superior vena cava syndrome is serious. Patient with the lung cancer or lymphoma, they could present with that, and especially the small cell lung cancer. Diagnosis, clinical imaging, chest X-ray, widened mediastinum, right chest mass, CT or MRI, intrinsic or extrinsic obstruction, collateral circulation. Venography, usually the gold standard test. Treatment, general supportive measures, head elevation, oxygen, steroid, diuretics, anticoagulation, low molecular weight, GOAC, apixaban. But remember, thrombolytics therapy only within 7 days of the presentation, because there is a risk of bleeding. So that is not a common treatment, but is option. Stenting and angioplasty, radiation therapy, chemo radiation. The goal of treatment to alleviate symptoms, endogenous stenting, thrombectomy, treat the underlying disease, chemosensitive cancer like a small cell lung cancer, non-Hodgkin lymphoma, germ cell tumor, chemotherapy could be enough to treat the SVC. Non-small cell lung cancer is not that sensitive to chemotherapy, so radiation with or without chemotherapy if it is non-small cell lung cancer. Thymoma, thymic carcinoma may consider surgery. Mild or moderate, if it is cancer, catheter-related thrombus, anticoagulation, and remove the catheter. Malignant obstruction, anticoagulation. Just stabilize patient, of course. And then the very last is spinal cord compression, which is another emergency. So spinal cord compression, fortunately, is not very common. 1 to 5% of cancer patients develop spinal cord compression, 95% due to extradural metastasis, vertebral, and usually thoracic. This is, you are more expert than most of you because you have training on radiation. I'm not, but we see them with radiation, with our colleagues from radiation. Untreated spinal cord compression lead to paralysis, sensory loss, incontinence, urinary retention. Most common in adults, metastatic solid tumor, lung, breast, prostate, multiple myeloma. It's just a presentation. As we said, 60 to 80% or 70% from thoracic metastases lead to paraplegia, upper lumbar, or caudal pinna. Both or either of them lead to bowel bladder dysfunction. Presentation. It's just a presentation. The weakness just here. I want to mention this here. Once neurologic symptom develop, it can evolve rapidly to paraplegia in hours or days. So that's why we consider it as an emergency. And once a serious neurologic deficit develops, less than 10% of patients regain function. If it's done, it's done. So it is to prevent rather than to treat. Diagnosis: X-rays. X-rays showed lytic and plastic lesions, erosion of the pedicles. Stat MRI of entire spines, myelogram or MRI. Treatment: usually pain control, opioid and laxative, of course. Neurologic deficit and pain management. We use a steroid, we use dexamethasone 10 milligram IV followed by 16 milligram on divided doses. Typically, we give 4 milligram every 6 hours. I think that most of the people do the same. And tapered steroid once definitive treatment initiated. We don't forget DVT prophylaxis, definitive treatment. The important is to assess for spinal stability, clinical exam, radiographic, extent of grade of spinal cord compression, radio sensitivity of the primary tumor. We need to know the primary. Unstable retropulsion of bone fragments into spinal cord lead to for that we need surgical decompression immediately and fixation followed by radiation. If the cancer is radio sensitive, we use radiation, of course. Radio resistant, we use the stereotactic. So I'm sorry it's taking long, and I hope you follow with me with this. Take-home message: we are in the last 3 slides for the take-home messages. Message 1: oncologic emergencies are few but carry high morbidities and mortalities. Be vigilant and with a high suspicion when a cancer patient walk in brought to your ER. Neutropenic fever. The common pathogens are indigenous, so the patient from his or her own. C. diff and gram-negative incidence is rising, unfortunately. First, this is the thing. First dose of broad-spectrum antibiotics like cefepime within 30 to 60 minutes is a lifesaver. Reduce mortality and save life. For tumor lysis syndrome, remember it is subtle but lethal. It is subtle, so it could be just a lab that's abnormal. The patient looks fine, and then all of a sudden succumb to his condition in the ER and die. So it is subtle but lethal metabolic disorder. Aggressive fluid resuscitation and electrolyte management aggressively. Use Respiricase as one of the someone mentioned that is, as she said, you use Respiricase, not allopurinol for hyperuricemia. Allopurinol for prophylaxis, Respiricase for treatment. Take home message number 2: hypercalcemia of malignancy. Remember the magic number 14, calcium corrected. Remember, corrected calcium. So don't be deceived by the calcium of 12, albumin of 2. You have to correct the calcium, the corrected calcium. If it is 14 or more than 14, admit patient, treat aggressively. Why? Because of a high risk for cardiac arrest and death. Hyperviscosity syndrome, also lethal if missed. Be highly suspicious if it is in patient with Waldenstrom or multiple myeloma. Symptoms for symptomatic hyperviscosity syndrome, we treat with plasmapheresis. The gold standard test is serum viscosity of more than 4. That is classic for the symptomatic hyperviscosity syndrome, and plasmapheresis is the way to go. Immune-related toxicities, remember, rapid identification, interruption of immune checkpoint inhibitor, prompt initiation of systemic high-dose steroid. Case number 3, slide number 3, sorry, spinal cord compression, cancer patient with progressive back pain, aggravated by movement is considered spinal cord compression until proven otherwise. Emergency treatment, dexamethasone, the 10 milligram IV push or 10 milligram dexamethasone immediately, and then 16 milligram per day divided doses, and radiation therapy, radiation oncology at least consultation as an emergency, surgical decompression for unstable spines. For SBC syndrome, it is a clinical diagnosis, lethal if missed or untreated. The goal of therapy is to alleviate symptoms and treat underlying disease. And that is it.
Thank you so much دكتور الشامي. قضينا وقتا ممتعا معك. الفلور مفتوح for discussion. I'm sure there will be a lot of discussion in this very fruitful lecture. أتمنى من الجميع يعني ينزعوا عنهم ثوب الحياء ويتواصل. أنا أتوقع 3 أو 4 أسئلة كده. إذا ما في حد حيسأل أنا حسأل. أنا هختار. مش حسأل، هختار. يا دكتور وليد، رافع يدك.
السلام عليكم، يعطيك العافية دكتور الشامي، صراحة كانت very nice and comprehensive lecture، ما شاء الله تبارك الله يعني. To the point. سؤال فقط. In patients with established febrile neutropenia, true يعني الأسكو and I think the IDSA they recommend against routine use of the GCSF in these patients. But I think they have put some consideration, like in a patient with severe sepsis or an elderly patient or a patient with pneumonia. I think we can use the GCSF, but I'm not sure. Yani, just from your own experience or intake.
Yeah. Actually, to be honest with you, we all use it. We all use. If I see a patient with neutropenia, come to the ER even 10, 14 days from chemotherapy, we all do. But is it effective? Really not. Nothing. There is no proof that GCSF beyond the nadir is effective. It is effective as prophylaxis. That is documented. And it doesn't treat really, it just shortens the duration of the neutropenia. That's all it does, correct? Because when we give the GCSF, basically just shorten that duration, and instead of if the neutropenia is going to be for 7 days, it could be 2 days, 3 days, shorter it. But once it happened, then there is no proof that it helped. But general practice, we all do. Myself, I do it. But really, there is no proof that it has a role. So if we use it, so my own practice, the way I do it, the first cycle of chemotherapy, I gave chemotherapy without it, but check the CBC every week. So to catch the neutropenia. If there is neutropenia, it's not going to be that severe. So you be prepared for the second cycle, you give it with GCSF to prevent. So it is proven prophylaxis, not a treatment.
تمام.
Thank you. Clear. Thank you. يعطيكم العافية.
Okay. Who will be the next? طيب. إله.
السلام عليكم.
عليكم السلام.
I would like to ask about الأليبيدينول dose. هنا في السودان ما عندنا الريبيوريكيز، فبنستخدم الأليبيدينول as prophylaxis and as treatment. بس عايزة أزن الدوز بتاعت الأليبيدينول.
طيب allopurinol, when you use it for a patient already with high uric acid, it doesn't do much. It may lower, accelerating the hyperuricemia, but that high uric acid there, allopurinol does nothing for it. There is no harm of adding it, assuming that you can make the assumption or the theory that it prevent new or more uric acid accumulation. But the uric acid that is released from the damaged cells, allopurinol does nothing to it. So using it, adding it, because there is no respiratory, I don't see there's a harm, but it just we don't give it and expect to to improve the outcome. If it's nothing, then I will rely on other means like hydration and just just basically more supportive care, supportive measures rather than focus on the uric acid itself, if respiratory case is not available. But having said that, I think if we know that is, because usually we give allopurinol if we suspect the patient to develop hyperuricemia, like small cell lung cancer, lymphomas with the high tumor burden. So if the respiratory is not available, I will be using allopurinol more and more, just in case, because sometimes we don't give allopurinol for like a low-grade lymphoma or a non-small cell lung cancer or those kind of cancers. So if there is any hint that the patient may end up with high uric acid, I would just use it as prophylaxis.
Okay. One more question, then we can close the session. And I have exceed now 1 ساعة وثلث
I'm
يعني.
asking
Yes.
I'm asking about the mask score in management of febrile neutropenia.
Say it again.
I'm asking about the mask score
Damascus. Okay.
in the management of febrile.
Of the neutropenic fever.
Yeah.
Well, what do you want to know about it?
Maybe she want to ask about, is it, how we can use it and to apply it in clinical practice?
Yeah, sure.
Is it
the same thing we use for the SIRS. So it is one of the means that is to grade or see how severe is the neutropenia and how to act. So simply, I just use the SIRS. If there is any, basically, we just say more than 2 of those scores of those, like the blood pressure less than 90, the respiratory rate more than 20. If there's any more than 2 of those factors, we treat aggressively, and that means ICU monitoring and first dose of antibiotics within 30 to 60 minutes. So there are different scores for just basically just more of a critical care issue. So if there is anyone in the critical care we want to add, would be great.
شاكر لدكتور شامي، شاكر للجميع حضورهم. بداية أعتقد جيدة، وعلى الأقل ادتنا فرصة إنه نتواصل في الزوم من غير نقطعه لعدة أجزاء، وسيف برضو، وإن شاء الله هيكون في نحط محاضرات عليه.